Hello and welcome back to the Growth Paramedic channel. I'm your host Marvin, and on today's episode I thought it'd be fun to do something a little bit different. This is a tier list or ranking tier list video on the different types of presentations you may go to within the pre-hospital environment and ranking them in terms of their difficulty. And this is mainly from my experiences and a little bit of their pathophysiology and what you could potentially expect when you go to these patients. I did see this done by someone a couple months ago, and I thought, why not just do one as well? And let's get started. I think the first one on here is anaphylaxis, which is this one here with the rash. Now, I've gone to a few. They can be difficult initially to assess because when we know about anaphylaxis, it can be a multifaceted response. It's an exaggerated response. Sometimes it can be instant, and sometimes you can have an allergic reaction that can quickly progress into an anaphylactic reaction, or there's a threshold that's met with the amount of cell mediators released that it triggers a full system response. But with anaphylaxis, I'd probably say I'd lock in for this because, one of the key treatments for anaphylaxis in most countries is adrenaline. The sooner you can identify anaphylaxis, the better care you can provide. And the later you give adrenaline and the more time you allow anaphylaxis to take hold, the harder it is to get these patients back to a safe baseline. And so you can end up with something known as refractory anaphylaxis, where the treatment that you give is no longer effective because of how progressive anaphylaxis has occurred. So I'd probably put that in a lock-in state. So basically you gotta focus, gotta observe, gotta do your history taking. If you don't really focus as much all your energy into that case, these patients can turn around really quickly and give you a bad day. The next one is diabetic emergencies. So your hypoglycemic patients are really it's pretty standard. I don't think I'd put it in difficult, because once you get a BGL reading and they have a history of diabetes, a lot of times it's just identification. If their sugars are low, you can give them glucose, whether oral. If they're not really tolerating oral, you can give them IV glucose. If you can't get a line in, then glucagon IM. In these cases, if they're very high, you just need to take them to hospital. They need to get things done there. If they're low, you can start treating on scene. So I would say it's pretty stock standard to manage your diabetic emergencies. I guess when they're in the severe ends of the spectrum, where they're like hyperglycemic, like DKA, they can present a bit more deranged in their vital signs. So you may need to start managing those patients. So you can move to a more difficult area. But in most of the presentations with diabetes, it's pretty common and pretty standard to treat. So let's go with seizures. Seizures I'll probably put seizures on difficult. Because you can put it in challenging, but if we're talking about something like a tonic-clonic or a grand mal seizure, it's very obvious they're in a seizure state. And the treatment for a seizure is to stop the seizure. So we can give something like midazolam, a pharmacological intervention, to stop that seizure activity. But where things can go wrong is where they keep seizing, and then you need to give more medications, and they're not responsive. So you can end with something like status epilepticus, where seizure activity is non-responsive to medications. It's been going over for 5 minutes, or they haven't returned to baseline between seizure activities. Let's just say they've had a seizure, they've gone post-ictal, and rather than fully returning back to where they were before the seizure activity started, they have another seizure. Now, they can be difficult, but challenging. The main principles around seizure is identifying medication administration and then protecting that airway. We also need to be mindful of what's caused the seizure. Does this patient have a known history of epilepsy or an infection potentially? So, or it could be injury related. It could be a traumatic brain injury, and the patient's herniating. So I'd probably put seizures as, you can go either way. I'm going to put it as difficult. When you have a seizure that's ongoing, you can start to need to do a couple more things on scene. Chest pain. I think I'm gonna go with chest pain, like your STEMI. I will definitely put this as locked in, because these patients, I've seen it happen. If it's a STEMI on the ECG and they look sick, they're clutching their chest, they have a history that's suggestive of acute coronary syndrome, I would definitely be ensuring that I have my A game with these patients. I mean, I'd always have my A game, but in these particular cases, they are very much, until they get to a cath lab, they are peri-arrest. And I've seen it happen. I've seen patients who've arrested before I got there, patients who we've got them on the stretcher and they've arrested there, patients who are arrested in the ambulance, patients who have arrested just as we got to the cath lab. They're very much unpredictable in when they're going to arrest. And until that blockage is resolved, they're still getting oxygen deprived to those cardiac myocytes. So in those patients, you need to make sure you're on top of everything, IV access, paddles on, have a team game plan, airway plan, who's doing what, because these patients can change within seconds. Carbon monoxide poisoning, that's one I haven't gone to often, but it's definitely one that I would put in the locked in. A lot of times it's mainly for your safety, because with carbon monoxide poisoning, it's an odorless gas, and sometimes you may not notice its symptoms until it's actually taken hold. So think about your house fires or your enclosed spaces with heaters and all those things, or barbecue inside the house. Anywhere where there's no good source of continuous ventilation. That's probably a bigger concern of a carbon monoxide poisoning, or whether you've gone to a scene and all the people around it has collapsed, and as you walk towards it, which I wouldn't recommend, if you haven't done a dynamic risk assessment, if you get to the scene and you start getting a headache, I'd say get out of there, get the hazmat team involved, because again, carbon monoxide is just one of those silent, lethal, deadly things that we really don't want to be exposing ourselves to if we can. And they can also produce false negatives. So one of the things with carbon monoxide is that it has a high affinity to hemoglobin than oxygen. And so I think 240 times the affinity. And so you will have SpO2 readings or oxygen saturation saying 100%, but all of it's just carbon monoxide, not oxygen. And it's easy to get tunnel vision thinking, oh, well, the patient's got good oxygenation, when in fact they don't. And you need to start, aggressively providing oxygen therapy to those patients. So one of those things you need to lock in for, both for you and your patient safety. The next one is agitation. Agitation, delirium, just unexplained behavioral disturbance. I'm going to put that in challenging, mainly for also the physical part of it, but also trying to figure out why is the patient in that state. And that requires a lot of cognitive processing, trying to figure out, is this traumatic, is this medical, is this mental health or emotional? All these things come into play. So trying to do that in an environment where it's pretty chaotic. You may have police on scene trying to de-escalate the patient, or even trying to restrain them, and you're trying to find out, where do I go from here? Do I perhaps need to go down a medication route, such as sedating them, or can I verbally de-escalate enough that they will willingly do an assessment? And oftentimes you will go to a patient who might have an infection that is agitated. So those ones you have to start thinking, well, if they have a known cause of it and I give a medication that puts them to sleep, do I now need to manage the airway, and do I now need to do a whole bunch of other things that otherwise I could have avoided? So I'll put that in challenging with any form of agitation, behavioral disturbance, and also there's always complications. Anytime you have a patient who is agitated or behaviorally disturbed and you decide to sedate them, that should always be your last resort, because the moment you put them into a sedative state, you have to be ready for that patient to crash or to lose their airway. So always have a game plan if you do decide that this patient needs to be sedated for your safety, for their safety. Asthma, I'd probably go with, so it's, if we're going with just standard asthma, like you're someone who's had a flare-up of their asthma from exercise or something, I'd probably go with standard for that. It's a pretty obvious treatment, salbutamol, ipratropium bromide. If it gets more severe, then you need to start being more aggressive, potentially even giving adrenaline in your severe forms. But for the vast majority of asthmas, it's simply prompt recognition and getting those bronchioles open, reducing that bronchospasm and bronchosecretions. Croup, I use a seal for that, so like barking cough. I'd probably go with standard as well. If you hear a barking cough with a kid and they're febrile, they got croup. You know, you got suspicion of croup, and that itself is probably going to be a trip up to hospital to get them assessed. I guess where things can get a little bit more difficult is that if that croup or that barking cough or seal cough is accompanied by excessive muscle usage and obvious respiratory distress. But if you're just getting that barking cough that's characteristic of croup, most of the time just monitoring. In some services, should that progress to more a form of like a respiratory distress or acute respiratory distress, your ARDS, then you can go down that like nebulized adrenaline route, but only if your state kind of allows that. The next one is generally unwell. So it's pretty generic. You go to a patient, the MDT doesn't really have anything that's pinpoint. It kind of just says that the patient hasn't been feeling well for a couple of days, or they've been lethargic or a bit malaised. You kind of have to become a bit of a detective with these patients. I'd put that in standard, or difficult actually, because you don't really have an obvious cause for why they're presenting that way. Could be a range of things, and so you need to be able to get a good history taking, get a good vital sign survey, patient assessment, looking at all the social history, medical history, and then potentially go via a referral pathway should they not really meet the need to go to hospital. But it's still important with these patients that you don't drop the ball with them, so get a good comprehensive assessment. Now we have, what's this one? I think a couple of these are similar. I believe this is a syncope, yes. So syncope is someone having a faint. I would go down with probably difficult as well, because you need to figure out why did they have a faint. Was it from dehydration? Was it from a cardiac problem? What's their 12 lead? Was it from a stroke? Was it from a drop in blood pressure from standing, like postural hypotension? So those things you need to consider with syncope, and they may only have one episode of syncope and they might not have another one when you get there. So you didn't see what happened, so you can't validate, or you can't physically see what potentially may have caused that before, like what was the patient doing before they fainted. So those ones can be difficult in terms of getting a good understanding of what potentially caused it, because there can be a range of things, and most of the time if someone's had a faint and there's no obvious cause, it's a trip up to hospital. They need to get blood done, they need to be monitored. It could be something sinister. Next one is your very much common cold, flu-like symptoms. That's pretty standard. Someone's just been feeling a bit run down, they've got a runny nose. Just go through your comprehensive overview of history taking, patient assessment, vital sign survey. And in these cases, these patients can most likely manage on their own. I guess where you may need to start thinking about hospital transfer is if it's an older population and they're they're positive for something like COVID and they're not vaccinated, or they're known to have a history of needing antivirals, then that's going to be a trip up to hospital. But they're not the most challenging ones to go to, so I'd put that in standard. CPR. Look, CPR is our bread and butter, especially for adults. Pediatrics is a little bit of a different story. While it is standard, I'll still put it in as difficult. Yeah. Look, I'm going to put CPR standard. It's one of the things that we are really, really good at as pre-hospital clinicians. If we recognize someone's in cardiac arrest, we straight on the chest, straight to managing the airway. We're doing the first shock coach cycle. It is our bread and butter. So I'm going to put that in our standard range. And then we've got our choking. I'm definitely going to chuck that into lock-in, because if they're actively choking, you want to get that foreign obstruction out of that airway. Because if you don't, you now have a cardiac arrest in your hands. And these patients would go into a hypoxic arrest or respiratory arrest. And so if you can't get it out, you need to start working on trying to get whatever that thing that was stuck in their throat out as soon as you can. Because as much as chest compressions are going to circulate flow or blood flow around the body, it's not going to replace the oxygen deprived lungs that the blockage has caused. And hey, chest compressions may help dislodge the blockage, but you may end up, if these patients end up arresting on you, using a laryngoscope to go into the airway and to try and visually see where it is. Next one is, I believe this is depression or mental health. I would say these are challenging. And the reason why they're challenging is no two people are the same with mental health. You need to look at the full picture, and you may have only met this patient for the first time, and they could have an extensive medical mental health history. They may have gone to hospital a couple times, and they may have a bad experience with pre-hospital providers. And so you're trying to climb an uphill battle with these patients, because you need to build that rapport, and they're very sensitive to the words that you say. So you can spend a whole hour building up rapport, but if you say one word wrong or one question wrong, or you sound demeaning or aggressive, they can very quickly shut down and stop communicating with you. Also, you need to think about the different variations, because compensating capacity, yes, that's important to assess in these patients. But looking at their mental state, how they're presenting, how they're talking, what have they been doing recently? Do they have suicidal ideations? Have they tried to harm themselves? Do they have a plan? What's their current treatment plan for their depression, anxiety? Are they on medications? Are they compliant with the medications? Do they see a psychologist? Which hospital do they go to? All these questions you need to ask, but not overflood them with those questions. You need to slowly build them up in a way that's more of a clinical conversation rather than an interrogation. So these can be challenging. They can take a while to assess on scene, but it's important that you don't rush these kind of cases, because it's so much harder once they shut down on you, especially when they lose that trust in your assessment and care. The next one is burns. I would say they're challenging. It also depends on where the burn is. If this burn was in the airway, I'd say like an airway burn, like inhalation, I'd probably say lock in. But I'm going to put it for burns, at least from my experiences. The principle for burn injuries is just cooling down the burns, protecting it from the outside environment, and giving fluids where indicated. And they need to go to a burns unit. So pretty stock standard. But they do look quite intimidating, especially some of the more severe burns. When your skin's like that, if you haven't seen one before, it can be quite confronting. Mass casualty events. I'm definitely going to put that as in locked in. Massive time where cognitive overload will be present. There's a lot of things going on. There's a lot of patients. You need to make quick, rapid decisions. You need to triage. You need to sieve. You need to figure out who is the most sick, who needs my help, who you may not be able to save. So they're definitely in there. You have to really lock in with these cases. Next one is shoulder dystocia. Oh, sorry. I'm looking at the shoulder. It's shoulder dislocation. I'm going to put that with difficult. If you have someone who's trained and it's still dislocated, they may try to put it back in. But most of the time with a shoulder dislocation, it's mainly pain relief. They're going to be in a lot of pain. They probably need to get an x-ray. But with these ones, just managing that pain and keeping them comfortable is the principle that we can provide to them within the pre-hospital environment. Drowning, I'd say lock in for that one as well. With drowning patients, especially if it's something like saltwater drowning, where they're in the beach and they've consumed a lot of water, they've drowned, they went into arrest, and let's just say you brought them back, you need to be aware that the salt water does cause a lot of irritation to the lungs. It disrupts the surfactant, and it causes increased permeability to the alveoli, so you can get what we know as secondary drowning later on, where the lungs become full of fluid that's leaked out from the capillaries into the alveoli. And drownings in themselves can be challenging because when you're ventilating these patients, if they're full of fluid from inhaling all that water, you will need to use something like PEEP to try and open up those collapsed alveoli. So they can be a lot more challenging cardiac arrest patients, but definitely it'd be, if you are with a patient who's drowned and then cardiac arrest, you'd just be doing your standard cardiac arrest protocols and treating that reversible cause. Stabbings, I'd go with locked in. I haven't gone to many myself, but they're always very, very dangerous jobs to go to. Make sure that you're protecting yourself, and as you've done a scene safety, you have police on scene. But with any stabbing injuries, if it's still impaled, please don't remove it. You got to immobilize them. You got to make sure that whatever's been impaled has been safely splintered. And if there is an open wound from a stabbing, make sure that that area is controlled using hemorrhage control techniques. But there's a big risk of losing a lot of blood very quickly, damaging multiple organs, and it also depends on which part of the body the patient has been stabbed. Falls in elderly, I'm going to go with pretty standard. I work in a service that does go to a lot of elderly falls, and so we do go to them fairly commonly. Those ones is making sure there's no further injuries. If they're on blood thinners and they've had a head strike, they will be going to hospital for a scan of their head, and you would be doing your falls risk assessment and looking at any potential abnormal vital signs. You're trying to figure out whether the fall was mechanical or medical in nature. Did they trip over something, or did they feel quite weak on their feet from a UTI or something like that? Birthing, I would say 100% locked in. I've had the privilege now of delivering 5 births within the pre-hospital field, and these jobs can be some of the most intimidating jobs you can go to. It's pretty good if it's a pretty stock standard one. Let's say they're 38 weeks gestation, you looked at the antenatal card and the baby's in the right position and they've started crowning. You're going to have to do the birth on scene. But most of the time, we really want to be prioritizing getting these patients to hospital, because there's so many complications that can happen with a birth. You have 2 patients. If the mother gives birth to the patient and they start having postpartum hemorrhage, you need to control that. You need to do a fundus massage. Or what if the baby then goes into cardiac arrest? You have a neonatal resuscitation on your hands. So it can very quickly spiral out of control, which is always a risk that you take if you decide that you're doing a pre-hospital birth. But they've been some of the most rewarding jobs I've gone to. Really, yeah, I can't explain the feeling I had when I helped deliver a baby, and just the sheer cry of joy from the family once they heard the baby cry. So it's definitely one you're locking in for. But it's when it's a good birth, it's such a rewarding part of the job, and it makes you feel quite privileged to be in the role that we are in as pre-hospital providers, as paramedics. Next one is fractures. I'm going to go with difficult. It all depends on where the fracture is, but a lot of times it's pain management and splinting the area, making sure there's no further damage to that site. It's a bit easier if it's a closed fracture, but if it's a compound, obviously treating and trying to prevent any further exposure to the environment because of the infection risk. Cold exposure, I guess environmental exposures can be challenging because it can also depend on where you are. Some places it's easier to get the patient out, and some other places it's harder. Let's just say you're in a bush track, it's cold in the middle of the night. You're going to have a hard time trying to get this patient outside of that cold environment. And sometimes these patients may need to be very much aggressively cooled down or warmed up. And there's a lot of other factors in play that can change the dynamic of the patient. So because they're hypothermic, they can become bradycardic. They can then go into cardiac arrest. If they're hyperthermic, they have derangement in their electrolytes. They can start having seizures. So you can have multiple different conditions presenting because of that exposure. Sepsis. Sepsis, I would put that in as... I probably put it in as a challenging. If you know there's a source of infection, you need to start aggressively treating the patient, resuscitation with fluids, get them to hospital. They need to get blood tests done, potentially IV antibiotics. But those patients can be challenging because they can present with an altered conscious state. They can be quite febrile. They can have a really low blood pressure, and you need to get that blood pressure up before they arrest on you and all that. Stroke, I'd probably put that as I put that as challenging. You don't know if it's going to be ischemic or hemorrhagic. The first thing you need to do in these cases is identify it. So you have your fast stroke analysis. So if they're fast positive, they got facial droop, they got arm or leg weakness, mainly to one side, or they can be to both sides. You got slurred speech, and it's within a time frame within 4 to 12 hours, then that patient needs to go to hospital ASAP for a scan. There's nothing else we can really do with our stroke patients aside from prioritizing extrication. You can get your IV access to help facilitate better care or transfer when you're in the hospital, but you can also be prepared for that patient to potentially go unconscious. If it's something like a hemorrhagic stroke, they could go into a Chen stroke breathing pattern, go unconscious, and now you have to manage that airway. Sprains and strains, I'm going to put that as standard. Just pain relief, some paracetamol, Nurofen. You might want to bandage that area. They'll probably go to hospital just to get a quick scan to make sure there's nothing further damage done to that area. But they're pretty standard jobs to go to. Nothing really terrible going on around sprains and strains. Most people recover quite well with those, but I guess it depends on what grade of strain or sprain it is. If it's a grade 3, you're probably looking at a much longer recovery time. Footling breech birth, I've not done, but if I did do an unlocking in, these patients, if you find in the antenatal card that they're not in the normal position for birth, normal birth position, just get them to hospital. Diesel, you have a potentially catastrophic birth impending, especially if they start having constant contractions. Spinal cord injuries, definitely lock in. If they got a known mechanism, if they got symptoms of spinal cord dysfunction, you want to protect that neck. You want to make sure that you're doing everything you can and to not move or worsen that spinal injury, because spinal injuries can be devastating, especially if they're young. Let's just say someone's horse riding, I guess, or on a motorcycle, they've fallen off and they've hit their head hard on a pole, and now they can't feel their feet or legs. Being paralyzed is a terrible fate, and especially if we can identify a potential spinal cord injury, we can make sure that they either don't move, or we are doing everything we can to ensure a smooth management of that spine in the pre-hospital environment. Third-degree heart blocks, I'm going to put in as locked in as well. There's no, it's probably one of the few ECG ones I've done, but there's no association, or there's no relationship between the P and QRS. In their severe third-degree heart blocks, you can have, a ventricular escape rhythm. So these patients are sick, and they can arrest on you. They can have really bad blood pressures. They can be quite faint, have altered state. There can be a lot of things going wrong. So you want to get back up. You want to get them to hospital. They're going to need a pacemaker. Lightning strike, I haven't gone to one. Obviously, there's a few things you gotta be careful of. That's probably electrocution burn. They could quite easily be in cardiac arrest. They could potentially be, exposed to the environment if they're outside where there's a lightning strike happening. So they can be very cold or it would mainly be very cold. But you also need to be thinking about your safety, because if they've been struck, I don't want to be struck in the same location. So obviously remove them from the danger if safe to do so. Adrenal crisis, I would say it's challenging. I think the big problem is identifying it. But if the patient has a history of Addison's disease and they know what the symptoms are and they're saying it's an adrenal crisis, which is where the adrenal glands don't produce enough cortisol, that's when you can kind of go down that route. Then okay, it's adrenal crisis. Let's start managing that. But when you do identify it, it is potentially life-threatening, and you need to get them to hospital. Left ventricular assist device. I have not done one of these things, but I have to say they very much intimidate me. It's essentially an external device that is used for patients who have severe heart failure, and it basically is a mechanical pump that's implanted, and it essentially gives them time for a heart transplant. But I've not gone to one. There are a couple patients that I've heard of that have had them, so it's probably one of those important ones that you want to be aware of, especially if one of these patients go into cardiac arrest from like a failure of the device. But in these cases, if there's something going wrong with that device, it's a return to sender, get them to hospital, get that device reviewed. Gunshots, I've not done one of these. We live in a beautiful place. We live in Australia. We do not have much gun violence. There has been some cases, but I've yet to go to one in my career, and hopefully not anytime soon. But yeah, they can be quite devastating. And if I did go to one, it'd be a locked-in kind of thing, because the cavities they can produce and the energy expelled in the body can be absolutely devastating to the organs and to all the tissue around it. Skin tears or wound care, that's pretty standard. Just cleaning the wound, irrigating it, making sure that that the site is removed of any excess bacteria, and they may need to go to hospital for another review or a referral pathway. Animal bites, they can be difficult. You can have multiple lacerations, multiple bites in different areas. They can be of different depths and different severities, and you got to be careful about rabies as well. And also making sure the animal that's actually caused the damage isn't in the vicinity when you're treating. So making sure that you remove that danger from yourself. And the last one I have here is your falls from height. I would definitely have that as locked in. It's probably heaps more that I can add, but just for a little bit of fun, I decided to put a couple of the presentations that you may go to. But with the fall in particular, if it's a fall greater than 3 meters, or it's a fall from a decent height, that can cause a lot of internal damage, spinal injury, traumatic brain injury, pneumothorax, hemothorax, fractured pelvis, fractured femurs, tibias, ulnars, like everything. So in those cases, you got to lock in, you got to make sure that you do everything you can for these patients. You're still doing that for everyone, but in some cases, it's more challenging, the clinical presentation. Anyway, I hope you guys enjoyed that. That was a fun little tier listing that I've done today. And if you had any questions or any others you wanted me to do, let me know in the comments.